Hi, this is Pat Iyer with Legal Nurse Podcast, and I have the pleasure of bringing you today three nurses with over 60 years of combined experience working with pediatric patients, and they are all legal nurse consultants. I have Karen Henkin and Deborah Woodbury and Jody Hancock with me today. Welcome to the show.
Thank you.
Pat.
I've had Karen on the show in the past. We talked about travel nursing and some of the challenges of being an international nurse. And we talked at the end of that podcast about bringing Karen back, and along with Karen, her team, to discuss one of the critical issues that affects the legal case resolution, which is litigation involving children. We are connected through the legal nurse consulting community, and the three nurses that I'm talking with today are all part of a business combined called Trifecta. So let's jump right into the subject. Why is early identification of pediatric decompensation such a critical issue for the care and the management of pediatric patients?
I'm going to answer that question, Pat. So something to remember about children is that they're very respiratory driven, and they're going to have respiratory failure, which then will lead to cardiac failure. But if you can fix their respiratory issues, then you can prevent that cardiac failure. Whereas with adults, typically you have cardiac failure and then respiratory failure. So when a child comes into the ER, the first things you want to assess is, same with adults, their airway. So what does their breathing sound like? Is it noisy? Are they vocalizing normally? If they're an older child, how are they sitting? Typically, if kids are having trouble breathing, they're going to kind of like sit up and kind of put their hands in front of them so that they're very upright. And they're not going to want to lay down at all because that makes it harder for them to breathe. You also want to think about if you have a child who's either too young to talk or maybe just nonverbal for whatever reason, do they have a foreign body in their airway? We all know that kids love to put things in their mouth, infants, children. You want to check your couch cushions because if you have money down there, they're going to find it and they're going to put it in their mouth and it's going to get stuck in their throat. I've even seen older kids who are just curious and they're like, I wonder what it would be like if I put this in my nose. So you're going to want to see, do they possibly have a foreign body? If they do, they're going to have some trouble breathing probably. They might be drooling. The other thing to think about is kids that have epiglottitis are going to have some of the same symptoms that kids with a foreign body have, such as trouble breathing and drooling. And then as far as respiratory symptoms and illnesses in kids, the four most common ones are asthma, croup, bronchiolitis, and pneumonia. Croup is very common in children that are older than 6 months, and they'll have this kind of like barky cough. Boys typically get croup more often than girls do, and it usually peaks in autumn, so we're kind of coming into croup season right now. And the other thing about croup is that kids will seem like they're perfectly fine, and then they will just wake up in the middle of the night and they will be in like distress and just they'll be very anxious, they're having a hard time breathing, and it's really scary for parents when kids have croup. And croup is usually caused by parainfluenza. Another thing that we see a lot, which I'm sure a lot of parents are familiar with, is bronchiolitis. This is the most common lower respiratory tract infection in children under the age of 2, and it's usually called by RSV, or respiratory syncytial virus. RSV is very, very common. Most kids, when they get to age 2, they've probably had it. The only treatment for RSV is supportive So it's suctioning, oxygen, hydration. Typically, RSV causes a lot of like nasal secretions, and kids have a really hard time clearing those secretions, and then they can't eat, they can't breathe. Um, Something that's helped with RSV treatment is there's now a vaccine which they give to high risk infants, like premature infants, people that have cardiac and lung um, problems, and that has really helped with the overall hospitalizations from RSV. It's dropped by about 50% overall. And finally, pneumonia. Pneumonia is the #1 cause of mortality for children worldwide. It kills more people than diarrhea, AIDS, and malaria. And if you think about third world countries and how much problems they have with like diarrheal illness and malaria, like that's a huge, huge thing. And kind of a unique situation to think about for legal nurse consultants is that unlike adults, children have multiple caregivers. So there can be problems when you have a child who spends time in 2 different households and maybe the parents aren't on the same page about what that child needs, or maybe just one parent doesn't know as much about the child's medical care. You know, adults can be non-compliant, but children are especially non-compliant, right? They don't want to take medicine. They don't want to, you know, do their respiratory treatments. They don't want to do, you know, anything that's not fun. So the parents really have to be their children's advocate. They have to enforce whatever needed health interventions, and they also have to really advocate for them when they know that something is wrong. Something that we also see on the flip side of that is that sometimes, you know, parents will bring their child into the hospital and they kind of disagree with what the medical team wants to do. And sometimes, you know, that's okay, but other times, you know, it can be a life or death thing. We've had infants who have come into the ER and they need a septic workup, and the parents have refused. And we have had to put medical holds on these children so that we can get them the workup that they really need. And something to pay attention to if you're a legal nurse consultant, if you have a case where this has happened, you really have to look and see, did the healthcare team educate those parents? Did they tell them, these are the risks if you don't do this? These are the risks if you delay this care, because that can have a huge, huge impact. And, you know, nobody wants to have to like make decisions for someone else's child, but I mean, sometimes that happens and you just have to. The other thing is, you know, sometimes I've seen situations where parents don't take their kids as seriously as maybe they should with their symptoms. There was a case where there was twins, and one of the twins had asthma, and this child was with his father. He was about 10 or 11 years old, so old enough to tell his dad, hey, like I'm having trouble breathing. He told his dad he was having trouble breathing. You know, dad was like, oh, just take some more of your medicine, and kind of like, you know, tried to manage it himself, but he was still having trouble. And he was like, Dad, I think I need to go to the doctor. And Dad was like, no, just take your medicine, you know, you'll be okay. And then eventually this little boy's twin went to his dad and said, no, Dad, I think you really need to listen to him. He's really having trouble. Well, by the time this poor child came into the ER, he was having a severe asthma attack. He ended up having a anoxic brain injury and was never the same. So, you know, parents need to be advocates, but the healthcare team need to be advocates too. But as a legal nurse consultant, you really need to make sure that there's documentation that the care providers try to educate these parents and get them on board, because that's super important for everyone to at least try to be on the same page.
Well, you've covered so many good points, Deborah, and you've brought up some issues that I think we all have to think about. You're highlighting that, especially for pneumonia, which I've seen several cases as a legal nurse consultant involving mismanagement of pneumonia, delay in diagnosis, with that high mortality rate, that is a critical type of care that could lead to a lawsuit, as well as if there was anoxic brain damage in a child and the damages are severe, that also could potentially cause a family to go to an attorney to have a case evaluated.
Yeah.
You also maybe think about my child who stuck a Tic Tac up his nose, and I was debating about whether I took him to the ER, and then I said, blow, Tic Tac shot across the room, and that was, we averted an ER visit for that one.
Saved you a copay, Pat.
How expensive that Tic Tac would have been.
That would have been an expensive Tic Tac.
You know, curiosity. Oh, I've got a hole here and I've got a Tic Tac, and maybe they match up. You know, you never know.
Mm-hmm.
Let's focus on the differences between adults and children. And you highlighted something that was really important in terms of how children will sit upright in order to be able to breathe. I also was thinking about my son, who as an adult developed mold in his home, which went into his sinuses and his lungs. And when we took him to the ER the day he was diagnosed, he literally couldn't lay down flat. He was gasping for breath. Let's focus on the differences between a child and an adult when it comes to anatomy. What are some of the critical things, and how do they play into the outcome for respiratory illnesses for kids?
Yeah, I could take this one, Pat. So there's a lot of differences between the pediatric population and the adult population. For example, infants primarily breathe through their nose for the first 6 months of life. So when an infant gets a respiratory illness, they're going to have more trouble breathing. They have trouble eating. They cannot take a bottle or breastfeed because their nares are occluded. They become dehydrated significantly, and it could lead to a respiratory emergency. Children also use their abdominal muscles to breathe. They don't use their diaphragm as much. Their intercostal and accessory muscles are not quite developed. You'll see more of a seesaw motion for breathing, grunting. Children also have in their mouth and throat a shorter and softer trachea. Their tonsils and adenoids can grow really fast, which can impede their airway. They have bigger tongues, especially infants, which can occlude their airway, and you have to do a little positioning, neck roll, little sniff position to kind of get that airway open and the tongue off the back of their throat. Infants and smaller children also have smaller lungs, and that can cause an increased respiratory rate just for adequate gas exchange. Children do really well compensating for quite a long time until they don't, and then they will crash very quickly. Just like Deborah was saying before. They have a softer, shorter upper airway, flatter nose and face. It makes it harder for a face mask seal. So there's a lot of positioning you have to do. Especially for smaller children and infants, they're not going to be able to blow their nose, cough effectively. So of course you have to do a lot of suctioning for them. So they're definitely different than the adult world for sure.
Very important distinctions.
Mm-hmm.
And then I know you've mentioned some of the common respiratory illnesses. Deborah covered some of those in her section. There's a lot of controversy right now about whether children can get COVID, what percentage of COVID patients are children. Is there a risk to the child? I just saw yesterday a message on Facebook that was posted by somebody who said, my neighbor's child, 6-year-old child, went to school for a week, got COVID in school, and is now dead.
Oh, God.
Can you comment on this issue, which may not necessarily lead to lawsuits right now, and the jury is still out on how people are going to react in the litigation world to COVID-related claims. But for the sake of people who are listening to this, who have their concerns about their own children or grandchildren, what can you tell us about that?
Well, Pat, I can take this one. This one's near and dear to my heart because I was really sick with COVID in April.
Mm.
And so I like to think I took one for the team, and moving forward, Trifecta is COVID-free, right? But just for the sake of time, let's address the two biggest myths around COVID in children. And the first is that children don't get that sick from COVID. And the second myth is children don't spread COVID as effectively as adults. So regarding the first myth, children don't get that sick from COVID, that's really entirely not true. So children represent about 9% of all COVID cases and about 1% of all the deaths. It's true that children are hospitalized less. So 8 children with COVID will go to the hospital compared to 165 adults with COVID. But per the CDC, if your child is admitted into the hospital with COVID, they will end up in the ICU at the same rate as an adult. So now when children do get sick with COVID, it manifests itself very, very differently than adults. So in adults, we're seeing quite a bit of respiratory involvement. But in kids, COVID is really attacking their entire system through an acute inflammatory response. And I'm sure you've heard it, it's called MIS. We call it multi-system inflammatory syndrome. And what that is, that's the child's like immune system in overdrive, and it causes massive inflammation to their blood vessels, to their vital organs. And this inflammation leads to blood clots, strokes, and multi-organ failure. And it looks a lot like Kawasaki's disease, which is another childhood illness which involves massive inflammation of the blood vessels. The scary thing about MIS is that almost half of the children that present to the hospital with MIS already have some level of coronary disease or cardiac involvement. So it's very, very important for the parents to get them in early. We can treat them and we can prevent long-term cardiac effects. So regarding the second issue or the myth where they say children can't spread COVID, and the answer to that seems to really lie in the age of the child. So Lowry's Children's Hospital in Chicago did a study that showed that children less than 5 years old carry 100 times the viral load of COVID in their upper respiratory system. And children, and that's under 5, and over 5, they carry the same amount of COVID viral load in their upper respiratory system. Now, does this mean they can spread it? The United States hasn't done a lot of research on this, but there's an incredible study out of South Korea. They had 65,000 participants, and it showed without a doubt that children over 10 spread COVID as well as adults do. And this was shown, Pat, I don't know if you heard, back in June in Georgia, there was a summer camp, an overnight camp where 597 staff and children attended. And by the end of the week, 260 of them had COVID.
Holy cow.
Yes.
Whoa.
So yeah. So obviously they can spread it. Now, out of that 260, 49% were over 10. So what they did is they contact traced that population, and it showed a massive transmission of virus to their family. So the CDC really recommends any child over 2 years old needs to wear a mask. And there are a lot of parents who have a lot of pushback against that and say, my child's not going to wear a mask. But mask wearing is not a substitute for the two most important things you can do with your child, and that's socially distance and good hand washing. Those are the two most important things, and those are things as a parent that you can control with your child and have them do.
You know, there's been headlines, Karen, and I'm sure you're aware of them, of the number of parents with 2-year-olds who won't wear masks on airplanes. And in some cases, one I can think of, the airplane had to turn back and abort the flight, and then, or at least abort the passengers, if I can use that word. And then in other cases, if the child won't cooperate while the plane is on the ground, remove the child and the parent before they ever get up in the air.
Mm-hmm.
Do you think that that's an overreaction on the airline's part?
I don't think it is, but here's the interesting thing. Right before they shut down the borders in February, my sister and I were traveling through Thailand and Vietnam, and we went through South Korea. And the one thing we noticed, and we were saying, is all the young children, 2 years old and less, were all wearing masks without a problem. And we were making the comment of, oh, in the United States, these kids wouldn't be wearing the mask. But there was so much compliance of these small children because their parents were wearing masks. We didn't see children fighting for masks. And this was something that other countries were doing way before the United States and before they closed the borders, because they were concerned about COVID in that area and they had heard about it. So I do feel, quite honestly, is from my actual experience, how was it that children from other countries, very small children, were wearing masks? You see videos of children in China going to school, young children with masks on, very compliant, no problems. So it leads me to believe that most of these children, more than likely, are never wearing a mask at home. And then when they go on an airplane, the parents are trying to put a mask on them for the first time. And a child is going to fight that. A child is, you're putting something on their face. So what I would strongly recommend is that if airlines are holding true to this for the safety of everyone, we need to think globally. We need to think of a community now. Is that if you know you're going to be traveling and you have a small child, start practicing at home wearing a mask before that trip. Don't bring a mask and try to put it on the child right in that moment when you're sitting on an airplane, because there's a very good chance it's not going to work. So what I would do is start that behavior modification in preparation of that trip, make it fun, wear masks at home, get the child used to it, talk about when we go on the big airplane, we're going to have to put, our mask on. But I feel like sometimes the parents may be setting the child up for failure by not exposing them or having them do these things, beforehand.
That's an excellent point, Karen. And as you were talking, I was thinking about a Japanese restaurant I went to in New Jersey many years ago. My friend and I were the only Caucasians in this restaurant. And there were many families with little kids, like a year to 2 to 3 years old. We were completely oblivious to the fact that these kids were in the room because they sat in their seat and they ate quietly and they weren't running around and they weren't making noise and they weren't screaming and they weren't having temper tantrums. And I remember thinking, wow, what a difference in the way their parents taught them this is how we behave versus a family where the rules are relaxed or non-existent and the behavior is very different. And it made me realize that even little kids could follow the rules if that was the expectation.
Well, and Pat, you really have to see now how wearing masks in the United States, how now it's not a health issue anymore, it's a political statement. And here in the United States, we're the only country having issues with wearing a mask. And why is that? So I think if you look and if you see that if adults are having issues and problems with wearing masks, of course the children are. So it makes sense that in other countries, children absolutely follow the behavior of their parents, and it's up to the parents to reinforce and to create those behavior patterns in their children. And they certainly can do that. And so it's, you do see a very big difference in mask wearing in the United States versus other countries, definitely. Or lack thereof. Let me just say that.
And I think it's important to bring that up, Karen, because this podcast has listeners in 79 countries. There may be completely different rules and regulations where you, the listener, are seeing this podcast on our YouTube channel or listening to it on the audio channels. And we're being real transparent in our conversation that this is a problem in the United States, which is probably not news to anyone who's listening, but I think it's important to bring that up. I wanted to ask one more question just to tie this together in terms of the differences between adults and children. For people who've taken care of adults all their life, or legal nurse consultants who are very much in the adult mindset, what are the key things that impact the outcome for pediatric patients who get into trouble with respiratory issues? Why is this so much more of an issue for them than it is for adults?
So I think probably, and I'll take that one because it seems as though there's a big difference in the presentation in children and adults. And actually, Deborah touched a little bit on the fact that adults and children can present to the emergency room in respiratory distress, and initially it looks the same. It can be the higher work of breathing, the shortness of breath, the high respiratory rate, the low oxygen saturations, and obviously distress will progress to failure. But one of the key things that Deborah touched on is that typically with adults, there's a cardiac event or cardiac issue first that will lead to that respiratory failure. The important thing to remember with children is that it's completely the opposite. So unless a child has that underlying cardiac condition, it's very, very, very important to identify respiratory distress and issues early in children, because in children, almost all the time, if you correct those respiratory issues, you're going to automatically correct the cardiac issue that is coming with it, whether that's bradycardia or circulatory problems or poor perfusion. But I think the second thing to really consider as a nurse, and also I think as a legal nurse consultant and looking at the records, is just as a child presents to the, as a population presents to the emergency room, you really have to think about the cause. What is causing this respiratory issue? And Deborah touched on this. In children, it's predominantly infection. We talked about pneumonia, we talked about RSV, we talked about bronchiolitis, which is caused by an infection, croup, by virus, and then also epiglottitis, which is a swelling of the epiglottis, and that's caused by a bacterial or viral infection. Now, in adults, it's really completely different. It's because of heart failure, it's because of COPD, some pneumonia, could be a pulmonary embolism. So I think it's really, really important to think about the cause, and how if you don't treat children early on, it's gonna lead to a failure situation. And just as a quick side note, Pat, for your audience and the people who don't do a lot of pediatrics, one thing to consider is that when you have a small child present to you, especially a baby, and if initially they present with distress, with that high respiratory rate and irritability, and then they seem to get sleepy and start breathing slower, that's not necessarily a good sign. That typically means the child is tired, they're hypoxic, and that's an impending sign of respiratory failure. So if you're starting that IV on that child or doing something invasive and the baby's not crying, that's not just a mellow baby, that's a sick baby. So one thing to really remember, in the adult world, you can get an adult come in, and then as they get calm and they go to sleep and they breathe slower, you tend to say, okay, they're doing better. But with babies, not necessarily. So I've seen a lot of interventions happen late with children, and especially babies, going into respiratory failure, because when you laid eyes on them, you misdiagnosed them as sleeping, breathing slow, and happy, when really they were crashing and you didn't know it. So I think that's something really important to remember.
Yeah, can I just add to this, Pat?
Mm-hmm.
So I think the other thing is, I feel like with children, doctors have to have a wider differential, because they don't necessarily know what's going on with the child. Children are not as good about verbalizing their symptoms and describing what's going on. So you have to really have an open mind and think about everything. Whereas with adults, they can tell you more about how they're feeling and when things started and everything. I mean, some parents are great historians, but some of them aren't. And even if they are great historians, they're not going to necessarily know how much their kid has been struggling. So here's the thing so people always say, oh, how do you take care of kids? I could never take care of kids. It must be so hard. Well, actually, kids are so tough. They're so resilient. They will handle things like a boss until they don't. They will be sick and they'll still keep going. They'll do everything they can to keep playing. You know, they'll just go until they can't anymore. So you have to be thinking about all the possibilities when you look at a child and what is going on with them.
And children are good at compensating. They compensate very, very well until they don't.
Mm-hmm. Which I think brings us back to full circle of the legal nurse consultant who's evaluating these cases is placing a lot of emphasis on what the healthcare providers did in their use of critical thinking and their observation skills, because they can't rely on the patient to give a coherent history as you can with most adults.
Mm-hmm.
And you're highlighting the importance of early intervention because there's not that much of a safety net that separates that child from normal function and from being decompensating in their respiratory capabilities.
Mhm.
Yeah.
We've covered a lot of territory. I have a feeling we could talk for hours on this topic and not even scratch what you know about it. But it's my commitment to complete these programs in about 30 minutes. So I would like you to share with our listener, how can they find out more about you and about the services that you offer?
Jody, do you want to take that one?
Yeah, you can find us at trifectalegalnurse.com, and our phone number is 1-800-726-2679, and learn more about us.
Perfect. All right. Well, thank you so much for sharing your expertise about this challenging population that results in litigation when cases are not handled correctly. We all know about the breakdowns in communication, about errors that we haven't even touched on. Medication errors could be a whole separate topic, and how giving medications to pediatric patients is highly dependent upon the correct calculations. There are many opportunities for healthcare providers to get in trouble with this population. So I appreciate you sharing this one window of one aspect of pediatric care.
Thanks, Pat.
Yeah.
You're welcome. And thank you to you who's been watching this on our YouTube channel for Legal Nurse Business or listening to this on the audio platforms. Be sure to subscribe to this show with whatever platform you're using, and look for upcoming programs about legal nurse consulting that helps you build your business and motivate you and help you earn more money and do as good a job as you can for your clients. I'm Pat Iyer, and I have been talking with Karen Henkin and Deborah Woodbury and Jody Hancock about pediatric respiratory issues. Thanks so much. This is Pat Iyer with Legal Nurse Podcast. I have with me today Ellen Hahn, who is an experienced obstetrical nurse, has been a staff nurse, a manager, a clinical specialist, and educator. And we've just been chatting about obstetrical cases. Ellen, tell our viewer or our listener, what are some of the key points that you're going to cover in your podcast?
So I think today we're going to talk about common themes in obstetrical cases. We're going to talk about fetal monitoring and the importance of the nurse's responsibility in interpreting fetal monitor strips, in reporting issues to the physician. We're going to talk about oxytocin and its use and the nurse's responsibility in safe administration of oxytocin. We covered obstetrical hemorrhage and the importance of quantifying blood loss and the different causes of obstetrical hemorrhage and its implication. We talked very briefly, just touched for a second on hypertensive disorders, but we sort of ran out of time. And we talked about chain of command and the theme that I see in cases about chain of command and its importance in these cases, as I believe they are for all cases, the importance of communication between the nurse, the physician, and then moving up the chain of command if nurses are not getting the input from the physician and the action that they need.
Great. Well, thank you, Ellen. We did cover a lot of territory in this
We
show.
did. So, I mean, we could do a whole thing on preeclampsia and eclampsia, which, you know, when I first became a nurse, maybe 2 or 3 times a year, we'd get up the magnesium sulfate and open 40 little vials ourselves. And now we use mag like water. I mean, there's so much. There's just so much. But everybody's hypertensive and everybody's diabetic. But no, I hope it accomplished what you wanted it to.
Perfect. Well, thank you so
Okay.
much, Ellen.
Thank
And
you. It was great doing this. I really appreciate it. If there's anything else I can do, or if you hear someone that needs an OB nurse, just let me know.
Perfect. All right. So
Okay.
this has
All
been
right.
Pat Iyer and Ellen Hahn talking about obstetrical cases. Be sure to get that podcast and listen to it and use it, and think about Ellen in the future when you have an OB case.